Hi, this is Britt Liggett. I am a digital media consultant with DECA, and I'm coming to you from New York City, and I'd like to welcome you to the first DECA webinar. Tonight we have Dr. Kevin Kaiserman from Camp Conrad Chinnick in California, and he is here to talk to us about low-dose glucagon. Now, if you have any questions, please feel free to ask them, and right now I'm going to turn things over to Kevin.
My name is Kevin Kaiserman. I'm a pediatric endocrinologist in Southern California, and I am broadcasting to you this evening from Camp Conrad Chinnick in Southern California. And we currently have a group of about 100 8 to 13-year-olds running around outside while we are having our seminar. We're going to talk tonight about low dose or mini dose glucagon and our experience with using that here at our local camp, and hopefully answer any questions that you have as well. One important point to make before we get started is that this has been a voluntary program at our camp. This is not mandatory. We offer this as one of our treatment options, but no child or staff member is required to have glucagon while they're conscious. If they choose to go with the more traditional route of taking juice or other snacks, then that is perfectly fine. So a couple things to say up front is that it's very helpful if you can involve both the parents and your staff prior to initiating a new concept like low dose glucagon at your camp. We uh, because this is new to many families, it's nice to let them know ahead of time that you're going to introduce this as an option so that they can ask you questions or address it. The other thing to say is that we started using low dose glucagon at our camp many years ago based on our clinical practice of using low dose glucagon in children and young adults who have low blood sugars but are either unwilling or unable to take additional oral glucose, so they may be vomiting or they may have already taken so many carbohydrates that they don't feel they can consume anymore. And low dose glucagon in that setting has been very useful to prevent a more severe low blood sugar reaction. And so we first considered to do the to do this at our camp, and we addressed it with our staff. Now, there's a lot of misconceptions and fears around using glucagon. Many people have been trained that you only use glucagon if you are in an emergent situation, such as losing consciousness or having a hypoglycemic seizure. And so we want to dispel that rumor and also explain to people that glucagon is a naturally occurring hormone that is part of the physiologic regulation of glucose metabolism, and that while insulin is designed to lower blood sugar, glucagon is naturally designed to raise blood sugar. And so once we had that discussion with our staff, many of them had never tried low dose glucagon in their personal home life, but they did try it subsequently at camp, and they turned out that they actually found it to be a more reasonable experience in terms of dealing with a severe low. And many of the staff then will choose to do that going forward, and also to model that behavior for some of the younger campers as well. So the other comment I would make about rolling this out at your camps is that we rolled it out initially at one of our 8 sessions that we run each year, and we started with our oldest campers, with the teenagers. It can be done in any which way, but that's how we decided to do that. So just to start and give you some ideas about the overall goals and how we manage that in our camp setting, the first thing is that the goal is really to raise blood sugar in a quick way that is safe and with minimal side effects. And that is the goal of using the low dose glucagon, as opposed to using repeated doses of an oral carbohydrate such as juice or glucose tablets. Um, there is a range, obviously, in terms of the values for hypoglycemia, and our values, different camps will use different cutoffs for when they would consider to use low dose glucagon. One important point is the number alone is not really the key factor, but really the symptoms that the patient is exhibiting, or the camper. If they really have neuroglycopenic features, if they are disoriented, confused, lethargic, we would be more apt to use low-dose glucagon in that setting than if they are fully awake and alert and are willing to drink juice, even if their blood sugar is lower. So the cutoff is typically somewhere less than 50 or 60 milligrams per deciliter to consider using low dose glucagon. Again, preferably if they have other symptoms of low blood sugar and not just a numeric value alone. The other thing is that we ask the patient or staff member, the camper, if they would like to have a dose of glucagon or if they wanted to do the juice. And if they opt to have juice, that's always going to be the option that we will use. But many of them will opt, especially if they have a prior experience, they will opt to do the low dose glucagon. The dose that we use at camp, there's several doses that have been published. Typically, the dose that is mentioned is 1 unit of glucagon per year of age. So we typically use a dose in the smaller children. Right now, we have 8 to 13-year-olds. We draw up 5 units on an insulin syringe or 50 micrograms of glucagon. Or in the older kids, the teenagers, we usually start with a dose of 10 units on an insulin syringe or 100 micrograms of glucagon. We have used as much as 20 units or 200 micrograms for some of the larger staff members or young adults. One of the things that people like to ask is how often we will give the dose. We will typically only repeat the low dose glucagon once, so a total of 2 doses can be given. We also give a fast acting carbohydrate. When you retest 15 minutes later and their blood sugars are up, we will typically follow that up with another carbohydrate as well as a protein to help them until the next time that they are going to eat. There was a small trial that was done at our local camp and presented at last year's American Diabetes Association meetings as a poster, looking at a number of comparing treating low dose glucagon versus juice in 125 events. Of those 125 events, 47 of those were treated with low dose glucagon. And to just give you some numbers, the average blood sugar at the time of the low blood sugar, if they chose glucagon, the average blood sugar was 50 milligrams per deciliter, as opposed to the juice was 59 milligrams per deciliter. And the subsequent blood sugar, about 15 minutes later, went up to 94 milligrams per deciliter in the glucagon group and up to 84 milligrams in the group with juice. Now, one of the things about the study that's a little bit different is people were only treating with a single dose. And we are all aware that people often will retest too soon after having the juice or the glucagon and often end up repeating the treatment over and over again. And this ends up leading to significant rebound hyperglycemia in the next follow-up sugar. So one of the nice things about the glucagon is you get a more rapid and a little bit brisker response to the glucagon than we saw when using an oral carbohydrate. So particularly for the lower blood sugars, where you often have to give 2 or 3 repeat doses of a rapid-acting carbohydrate, the glucagon was often effective in just the single dose. With that being said, to reiterate the overall goals of the mini dose glucagon, it is to have a rapid response to low blood sugar, to quickly and effectively raise the blood sugar and without significant side effects. So when using low dose glucagon, we have not seen any of the typical side effects that are described with a standard rescue dose of glucagon used in a severe hypoglycemic event, such as finding a patient unconscious or having a seizure. So issues of prolonged nausea or vomiting have not been seen in our experience when using a low dose of glucagon. With that being said, I think that the couple things that are very important in terms of rolling this out at your camp is the concept of again, discussing this with both parents and staff and explaining that the glucagon is a natural hormonal regulation of glucose and is used routinely to raise blood sugar and naturally raises blood sugar in the body when people have excess insulin. And also the idea of interacting directly with the campers when discussing use of low dose glucagon. We talk to them about it and what the potential advantages or disadvantages of using low dose glucagon are. And I just want to address a couple of questions that have come in so far and be sure that I have adequately addressed them uh, to you. One of the questions that came in was whether there are a maximum number of doses that a camper can receive over a period of days. And so I want to reiterate that in any given day, we won't use more than 2 doses of the low dose glucagon. The concern here, of course, is that we deplete their glycogen stores and we no longer have the ability to get a rescue dose of glucagon if the individual needs it. So, one of the things that we typically do is after we would have an episode with a where we use either low dose or a rescue dose of glucagon, we typically will back off on their insulin doses subsequently, certainly for the next 12 to 24 hours. So during that time, obviously, we hope that the patient has an opportunity to replenish their glycogen stores. But I think that for us, certainly no more than 2 doses in a 24-hour period. And we have not had a situation that I can think of over the past several years where we've had to do that more than treat the same person more than once or twice in an entire camp session. Our sessions usually run 7 to 12 days. So part of it is making other adjustments to their insulin doses after the mini dose glucagon. I will point out that we had an episode last night where one of our staff members came into the infirmary with a blood sugar that was initially tested at 33, and she had a juice and had opted not to take low dose glucagon, but several minutes later she was still feeling very poorly and retested, and her blood sugar was down at 25 milligrams per deciliter, and she opted at that point to take a low dose of glucagon when she was complaining that she felt like she was about to pass out. She took just 10 units, and this is a 17, 18-year-old staff member, took 10 units on an insulin syringe or 100 micrograms, and within about 10 to 15 minutes had a repeat blood sugar that was 77, and she felt much better at that point. So again, part of it is going through these opportunities, and spoke to her this morning before I did the webinar, and she said that she had no side effects and would certainly opt to do the low dose glucagon in a similar situation going forward, not only at camp but also in the home setting as well. And again, the reason for low dose glucagon is to try to preempt the need for a rescue dose of glucagon. So part of it is really dispelling the anxiety about the use of glucagon only in emergent situations. There's a second question about using mini dose glucagon only after blood sugars have not resolved with more than 60 grams of carbohydrate. Again, in our setting, we're trying to use mini dose glucagon as actually a first line treatment in campers that have blood sugars that are significantly low, typically around 50 milligrams per deciliter or lower, along with symptoms consistent with neuroglycopenic effects of hypoglycemia, disorientation, lethargy, and again, impending sense of like last night, the camper that described that she felt like she was about to pass out. In those settings, that's when we would typically offer low dose glucagon as an initial treatment, even prior to using juice, although they often get a juice at the same time anyway, because they often get a single dose of juice right when they first come in and describe that they're low, even while they're often drawing or pulling up the low dose glucagon.